Hello, everyone, and welcome to today's webinar. This webinar is a little different from our regular webinars because it is being presented by both STEM Lyceums and the Teacher Enrichment Program of the Center for Excellence in Education. My name is Shannon Tyler, and I am the Teacher Enrichment Program here at CEE. I am joined today by Rebecca Carter, the STEM Lyceums Program Manager, and we will be hosting today's webinar titled Modeling the Spread, Insights on Public Health and Disease Control. We are very excited to host our speaker for today's webinar, Dr. Lauren Ancel Meyers, and we can't wait to hear her talk. So without further ado, let's get started. To begin, I'd like to give some brief background information on our organization. The Center for Excellence in Education was founded in 1983 by Joanne DeGennaro and Admiral Rickover, father of the nuclear navy and civilian uses of nuclear power. Its mission is to nurture high school and university scholars to careers of excellence in leadership in STEM. We have cost-free programs for teachers and students, including the Research Science Institute, RSI, USA Bio-Olympiad, or USABO, the Teacher Enrichment Program, TEP, and STEM Lyceums. I'm going to talk a little bit more about these programs on the next slides. So first, we have the Research Science Institute, which is a highly competitive 6-week summer science and engineering program open to rising high school seniors, so juniors are eligible to apply. RSI is the first cost-free summer science and engineering program that combines on-campus coursework in scientific theory with off-campus work in science and technology research. Next, we have the USA Bio-Olympiad, or USABO, which is the premier biology competition for high school students in the United States. It provides the motivation, curricular resources, and skills training to take them beyond their classroom experience to the level of international competitiveness. And then a little fun fact about CEE. Since CEE began administering the USABO in 2003, every member of the USA Bio-Olympiad team has medaled at the International Biology Olympiad. Next, we have the two programs that are presenting this webinar to you today. The Teacher Enrichment Program, or TEP, which provides opportunities for middle and high school teachers to connect with leading experts from industry and academia, explore cutting-edge research and development, and make meaningful professional leaps with direct benefits for you and your student. Finally, we have our newest initiative at CEE, STEM Lyceums, which is a virtual club for high school students to engage in discussions and exploration of STEM and to learn about STEM career pathways. Now, I am very happy to introduce today's speaker, Dr. Lauren Ancel Meyers. Dr. Meyers is a distinguished epidemiologist and data scientist renowned for her expertise in pandemic modeling and the design of equitable strategies to combat infectious diseases. She holds a chaired professorship in integrative biology, statistics, and data sciences, and population health at the University of Texas at Austin. As the director of the UT COVID-19 Modeling Consortium, Dr. Meyers led an international team in developing advanced forecasting tools, designing effective mitigation strategies, and advising global health authorities, including the WHO, CDC, and policymakers worldwide. Today, she directs a $30 million CDC-funded initiative aimed at modernizing the nation's outbreak forecasting infrastructure. Dr. Meyers is the president and co-founder of the Center for Advanced Pathogen Threat and Response Simulation, a nonprofit leveraging serious gaming to revolutionize the science and practice of pandemic preparedness. She also chairs the CDC's Board of Scientific Counselors for Infectious Diseases and serves on the Harvard University Board of Overseers. Through her scholarly publications, public lectures, and media engagements, Dr. Meyers bridges the gap between science and society, fostering collaboration and informed decision-making. As a dedicated educator, she empowers students to address global health challenges ethically and effectively. So with that, thank you to Dr. Meyers for joining us today. We are excited to hear your presentation, and I'll turn it over to you.
Wonderful. Thank you so much, Shannon and Rebecca, for having me here today and for the really nice introduction. I'm very excited to see the list of attendees in the attendee box. So thanks for joining us today. I think you didn't say in your introduction for me is that I got my inspiration and part of my start by attending the Research Science Institute back in 1990, long before you were even like ideas in the figment of your parents' imaginations. But anyway, I go way back with CEE, and I owe CEE so much for helping me launch and vision my career. And I'm really glad to see that all of you are here who are also being impacted by CE. Okay, so let me share my screen and jump into the presentation. I've been building mathematical and computational models to help us understand how infectious diseases emerge into outbreaks, how they turn into epidemics and even pandemics, and how we can use limited resources and different kinds of policies to stop their spread. It's hard to actually put my profession in a clear bucket. I'm in a biology department and I'm in a statistics department. I'm also in a medical school, but I often refer to myself as a computational epidemiologist because that's what I do. I use computational methods to understand epidemiology. So I'm going to tell you three stories just over the course of my career, sort of meant to kind of explain to you sort of what I do in my research life. So when there is not a serious outbreak happening or a threatening pandemic, I am usually using mathematical modeling and using statistics to try to understand at a very fundamental level how pathogens, how viruses and bacteria and other things that infect us, how they spread among humans and other hosts, how they evolve as they're spreading, and how we can change the way they spread by intervening in different ways. But when there is an emergency, when there is a public health threat, like the COVID pandemic, I often drop what I'm doing, my basic research, and I and my lab, my team, we devote most of our time to building models to help understand the threat and respond to the threat. So what are the three stories I want to tell you? The first one goes back to when I was first came to the University of Texas as a new professor. I was sitting at my desk and my phone rang. And this was back in the days where this is how we communicated with each other. The thing on your desk would ring, you'd pick it up, and you wouldn't necessarily know who would be on the other end. So I picked up the phone and I said, hello, this is newly minted Professor Lauren Ancel Meyers. How can I help you? And the person on the other end of the phone said, hello, I am calling you from the British Columbia Centers for Disease Control in Vancouver. And we just identified our first case of this new virus. This was SARS-1. And we don't know what's going to happen. We don't know how it's going to spread in Vancouver. And we don't know what measures we should take to stop its spread. And we're calling you because we read a paper that you published with the CDC last year, where you built a mathematical model that helped them understand how it was going to spread and how to control the outbreak. So they asked if I'd be willing to help them build a model of SARS spreading in Vancouver. And I jumped on board immediately. And I spent the next several months working closely with the public health department in Vancouver to build a model that simulated the spread of SARS in Vancouver and help them figure out how they should contain it. Fast forward 6 years, and it's 2009, also probably before, or when you guys were probably pretty young or maybe not even born yet, there was a pandemic. It was the 2009 H1N1 pandemic. The reason you may not remember it or may not have heard of it was because it turned out to be really mild. It was an influenza pandemic, and it turned out to be not really any more deadly than the normal epidemics we have every year in the winter of influenza. But when it first emerged and the first cases and deaths were reported in Mexico City, we didn't know it was going to be mild. It was very scary. And so I got a phone call at that time on my probably first iPhone from my program officer at NIH. So this is a government agency that was providing funding so that I could do research on how outbreaks spread and emerge. And my program officer called me and said, well, you have a grant to work on, this certain set of research projects, but we're calling you to tell you to stop doing that research and help us by building models that will let us anticipate how this new pandemic is going to spread around the United States and help us figure out how we can slow its spread until we develop effective vaccines. And this was early on when we thought this might be more deadly. And the specific project they asked us to do that we worked on was to build a model of flu spreading all across the United States and help them figure out how they should use the strategic national stockpile of influenza antivirals. So you might have heard of Tamiflu, the thing we use to treat people if they have sort of a bad case of flu. Well, at that point in time, the US had a stockpile of 80 million courses of Tamiflu. And what they didn't know, because we have a population of 300 million people, is how do you use 80 million courses of drugs to protect a population of 300 million people from what might be a very deadly virus. And so we built a model and we helped them figure out when and where they should start distributing those antivirals to different cities around the country if it turned out this was a very deadly influenza. Fortunately, it turned out not to be very deadly, and they held on to most of the stockpile and hopefully still have it today. And then fast forward to the pandemic you all probably remember, the COVID pandemic. This time, the news alerts came in on different technology. Maybe I first heard on my Apple Watch, I don't know. But this was the most serious of the three threats that I'm talking about today. And it is the threat that we did the most work. We worked day and night for 2 years, building models to try to help the world, local communities, international organizations understand what this emerging threat was all about and figure out how to effectively prevent people from dying and from being exposed to this virus. And I'm going to talk to you today mostly about the modeling that we did between 2020 and 2022 to help combat COVID-19. Okay, so I mentioned that calls come in, right? I got a call from the British Columbia Center for Disease Control for SARS-1. I got a call from my program officer in NIH during the 2009 pandemic. When COVID hit, and I had been working in this area of research for almost 20 years, I got calls from many different organizations because I had worked with them in the past, or they had seen work that I had published in the past. And the different organizations, different decision makers asking for the help of my research team in analyzing the emerging threat. This is an example of one of the very early requests I got. This was an email I got directly from the White House Coronavirus Task Force. The subject line said urgent modeling request. It was an email that probably went out to about a half dozen other researchers around the world who do similar kinds of work to me. We all got it at the same time. And what it said was, and let me just tell you, I got this on a Tuesday, okay? That said, this will be a time-sensitive and urgent request. Below, please see the series of parameters and outcomes we would like you to model. All that means is the inputs to your model and the outputs we want your model to tell us. We will need whatever results you can achieve by the close of business Wednesday. So remember, this is Tuesday. They want it by Wednesday, East Coast US time, or the opening of business on Thursday. Your results in that time frame will inform US policies. This was a crazy request. The amount of analysis that they were asking us to do is something that would have typically taken us 3 or even 6 months to do. Build a new model, make sure the model's working, analyze the model, make sure we like the results, present the results. They wanted us to turn this around in 24 to 48 hours. And we all did our very best. We had a working model of COVID. We very rapidly adapted it to answer the question they were asking. We gave them results by Thursday morning, I believe. We used that extra 12 hours to do what we could. And I think all the other groups did as well. So what was the question they asked us? Well, the question they asked us at that point in time, I think this was April, was all of the United States had basically shut down. We were all under stay-home orders, no matter what city you were in. And at that point, the White House Coronavirus Task Force was planning to reopen things in May. And the question was, if we really do reopen in May, how many people are going to die in the United States by the end of 2020? And our answer to that question was, well, we can't possibly forecast how many people are going to die in the next 9 months because we don't have a crystal ball about the policies you're going to enact, the government, and we don't have a crystal ball about how people are going to behave. If we knew those things, then we could probably make a pretty good forecast about how the disease would spread. But without that information, we couldn't. So instead of giving you a forecast, what we're going to do is we're going to give you a bunch of different scenario projections. These are what if projections. And this is what they looked like. If you don't do anything to control the virus, then we project that over 1 million people will die by the end of this year. If you figure out a way to either keep everybody at home or some other method to prevent people from spreading when they're out and about, then you might be able to limit deaths in the United States to under 50,000. And if you do something in between, complete lockdown and no control at all, we'll probably see hundreds of thousands of people die. And that is, in fact, what really happened in 2020, right? We closed down, then we opened, then we partially closed, then we fully closed, then we opened. And so what ended up happening was there were periods where we had waves and people died, and then periods where things were quiet. And at the end of 2020, There were a little under 400,000 deaths reported in the United States. But when scientists went back and tried to account for the deaths that weren't actually reported, these could have been deaths that happened at home, so they weren't recorded by a hospital, for example. The true death count was probably over 500,000 people in 2020. So our projections were pretty accurate, as were the projections of a lot of the other research teams that went through that same exercise. So before I tell you more about the kind of work that we did during COVID, I'm going to just take a step back and tell you about three different types of problems, or three different ways modelers can be helpful during an outbreak. The first way that we use models to help out is we use models to do detective work. We use models to help reduce uncertainty and explain basic things about how pathogens are spreading and where they're spreading. And I'll give you some examples of that in just a minute. So just answering basic questions about how outbreaks are spreading. The second type of job we do is we work as oracles. We use our models to try to forecast what's going to happen in the future. How many people are going to be infected or die in the next week or month or even several months? And the final thing we do is we work as engineers. We use our model to help decision makers solve tough problems, make good decisions about how they should intervene in the heat of an outbreak. So I'm going to go very quickly through each of these categories and show you how models can help with detective work, with projecting the future, and with engineering solutions. So let's talk about some of the very early detective work that we helped with early in the COVID pandemic. When the world first became aware that there was a new deadly virus that was infecting and killing people in Wuhan, China, there was a lot of uncertainty. At first, the reports were there were only a few people infected, and these are people who were directly exposed to infected animals in the wet markets of Wuhan. And then we heard that, oh, maybe there is a little bit of transmission within households if people are really, really sick. And then it sounded like there was a lot more transmission. This was spreading a lot more easily. And we just didn't know. And in China, we couldn't see all the data from China for a variety of reasons. But we needed to know as quickly as possible how fast this virus was spreading in Wuhan and how far it had already spread out of Wuhan. So our team went to work trying to answer those questions with the very limited data that were available. So how did we answer the question without actually being able to see how many people were infected in Wuhan? Well, we used the information that we had. One of the pieces of information that we had was where and when the first 19 cases were reported outside of Wuhan. The first case reported outside of Wuhan was in Bangkok, Thailand, and very shortly after, we saw cases in these other cities all over the world, including in January, there were cases reported in Seattle and Chicago. We also had information on the daily travel patterns by airplanes from Wuhan to every other city in the world. And so we built a model that did something like this. It simulated disease spreading in Wuhan, and it simulated people traveling out of Wuhan based on actual international air travel patterns. And we used that model to estimate how fast the disease was spreading in Wuhan in order for there to have been the cases appearing in Bangkok and Seattle and Chicago when they did appear. So using that indirect approach, what did we find? We found that by January 22nd, which was the day that Wuhan locked down and nobody was allowed to come in and out of Wuhan, our model suggested that the outbreak was doubling in size once every week. So you'd go from one case to 2 cases in 7 days, and then 4 cases, and then 8 cases, and then 16 cases week after week after week. And that by the time Wuhan locked down, there were already probably over 10,000 people infected in Wuhan. But what was China telling the world at that point? China was telling the world that there was only 425 cases. And to this day, that is the official case count for Wuhan for January, this period in early January. But several other research studies that came after ours corroborated this estimate that there were probably over 10,000 people already infected by the time Wuhan shut down. We use these estimates then to try to figure out, okay, if there are already 10,000 people in Wuhan And Wuhan just shut down on January 22nd, and people have been moving in and out of Wuhan this whole time. There must be more cases in other parts of the world than just the ones we've seen. And so we set out to try to estimate how many cases there were in other parts of China before Wuhan shut its doors. How did we do that? How far to figure out how far it spread out of Wuhan? We worked with a team of Chinese students who had access to cell phone mobility data for almost 1 billion people living in China. So how did they get access to this data? Well, a lot of people in China use Tencent, which is a social media platform, to communicate with each other and use other social media apps. And just like Google and Apple and our apps often track where we are every day, every minute of every day, so do these apps. And they were able to acquire data that showed us on a daily basis how frequently people were moving between different cities in China by air and by rail and by bus and by car. And we used that data to build a model of how many people were moving in and out of Wuhan during that time that COVID was first spreading. And using that model, we were able to estimate that there were at least 100 cities outside of Wuhan that already had outbreaks underway that hadn't yet been detected. And within a couple weeks of our projections, most of those outbreaks were confirmed in those cities. So that's an example of detective work, trying to figure out how fast is this emerging threat spreading and where is it already in the globe. The other example of detective work that I'm going to share was really the most surprising and scary work that we did in the entire pandemic. So what we wanted to know was when somebody gets sick with COVID, how quickly do they become infectious and infect other people? So how quickly does somebody gain the ability to infect other people? So it's about the person-to-person pace of transmission. And in order to estimate that, we go out and we try to figure out something called the serial interval. What is the serial interval? Suppose I get infected and then I infect you. The serial interval is the number of days between when I first feel symptoms and when you first feel symptoms. So let's say I start feeling sick on Monday, I infect you on Tuesday, and you start feeling sick on Friday. Well, it's been Monday, Tuesday, Wednesday, Thursday, Friday, 4 or 5 days. That is our serial interval between me feeling sick and you feeling sick. Why do we look at that? Why do we try to measure that? Well, because we often have no idea what day I actually infected you, right? That happens silently. But we do know when I feel sick, and we do know when you feel sick. So how did we go about estimating the serial interval when we had no data from China? Well, we worked again with a team of Chinese students who scraped the websites of 18 different public health departments in different provinces in China, looking for case reports. These were people who were actually infected with COVID. The local epidemiologist went in and did some investigation. So we looked for case reports where the patient, the case report included information on when the patient first developed symptoms, and they did investigation and they could narrow down who infected that person. That's often hard to do, but in the beginning of the pandemic, if somebody got infected in a city outside of Wuhan where there were no other cases reported, and it turned out that their spouse had just returned from traveling from Wuhan, and they were the only other person infected in that city, then they could do that detective work. Then they could say, okay, we believe this was the first person, they picked it up in Wuhan, and then they infected their spouse or someone else in their household or their work. And these Chinese students were able to find over 400 different case reports where we had a good idea of what that serial interval was. We knew who infected who and when they each felt symptoms. So using this data, our analysis was really simple. Any one of you could do this analysis. It was just take all these serial intervals and make a histogram. So this is a frequency distribution of those serial intervals for those 400 different cases. So how do you read this? Well, let's look here at 10. This means that 3 out of those 450 cases had a serial interval of 10 days, and 3 had 11 days, and 3 had 12 days, and only 1 had 13 days, right? So this is just a simple frequency distribution, a histogram, showing what the serial intervals were for those 450 cases. So we made this graph, and this graph may not look scary to you, but this graph was so scary to us because this was when we really didn't understand how easily this virus could spread. What did we notice about this? Well, there were 3 things. One was that the average serial interval was pretty short. It was about 4 days. So that means it was spreading from person to person at a pace that was too fast for us to be able to contain it with contact tracing and isolation, right? That means the public health agency and the contact tracers would have to be working at lightning speed to be able to identify everybody who had been infected in time to isolate them before they spread anything to anyone else. So this meant it was definitely too fast. It was going to be too fast to contain, given the resources we had for contact tracing and isolation in the United States and in much of the world. This was also kind of concerning. Sometimes people weren't infecting each other for weeks, after they were first had symptoms. So that meant if you were going to isolate someone and prevent them from spreading disease, you're going to have to isolate them for a long time. That was going to be very disruptive. But this was the scariest thing. This was the thing we didn't know until we made this graph. Negative serial intervals. What does that mean to have a serial interval of -5 or -3? That means that I was infected before, and then I infected you, but you actually had symptoms before I developed symptoms. Why is that scary? Or why was that scary? Well, that meant that I was infectious and I was contagious and I was spreading the disease to other people before I even knew I was sick, while I still felt healthy. So this was actually the first evidence that COVID could spread asymptomatically or pre-symptomatically before someone had symptoms. That was the nail in the coffin. That meant that this thing was spreading quickly and silently, and there was really nothing we could do to stop it from spreading all over the world and becoming a global pandemic. As soon as we made this graph and we shared this with our colleagues at the CDC, their response was, "You must have made a mistake. Go check your math." Because it was just so inconceivable at that moment in time that this was spreading that quickly and that silently. And unfortunately, this was true. And within a few days of us sharing this graph, the Chinese CDC shared similar information, and the whole world and the community, public health community and epidemiological community really knew at that point what we were in for. Now I'm going to talk about the second hat we wear as forecasters or oracles. And I'm not going to talk that much about this, even though this is probably what my field is most well known for, putting forecasts out there. So what does this mean? It means we're doing things like predicting into the future how many people are going to become infected, how many people are going to end up in hospitals, how many people are going to die from COVID or for whatever outbreak we're dealing with. And we do this all the time, and we got better and better at this during COVID because there was such a demand for forecasts. But this is an example of forecasts that my team made for all 50 states, and each state is sort of put on this approximately where they're located on the map of the United States. And this was some forecasts we made. I think this is either COVID or influenza. I can't remember. We forecast all of these every week. But what you can see is the actual data in these little dots. And then off the end, you see these little forecasts of what we think is going to happen in the next 4 weeks in terms of how many people are going to be in the hospital for COVID. And then this shading is indicating our uncertainty. We don't know for sure. So we're letting you know this is the range of what we think is possible. And you can see at this point in time, with the exception of a few places like Hawaii and Alaska, most states we're predicting that there's going to be a real upturn in hospitalizations over the next month. So this is a subject for a whole different talk, but this is one of the areas of really exciting innovation and research in my field. And we do this all the time, and we do this for diseases we know well, influenza, now COVID now, but we also try to build models so that when a new unexpected threat emerges, we can really quickly adapt our models to be able to understand and forecast that threat. So the job that I'm going to talk about last is where we use models to help engineer solutions. And this is where I'm going to spend most of my time. And this is where in this talk, and it's also where we spent most of our time during the COVID pandemic, trying to do analyses, trying to build models, trying to run simulations that actually helped decision makers solve practical questions that could save lives. And we did this kind of work on many different scales. We did this kind of work for working with global agencies and national agencies. But most of what we did was really close to home, working with decision makers in the city of Austin, Texas, where I live, and also in other parts of Texas, to navigate this really challenging situation. And the picture you see on your screen is a black and white image of downtown Austin and the lake that runs through town, which Austin's really a beautiful city. UT, this is my plug for UT for those of you who are still, young enough to be thinking about college in the years ahead. UT is a great public university with outstanding research, outstanding education in a really beautiful city. So UT. Okay, so how was it that I and my team at UT was able to do work that actually supported decision making, actually helped people navigate the challenges? Well, I was fortunate to be invited to serve on the executive task force, the executive COVID task force for the city of Austin. What was that task force? It was a really diverse group of experts and what we call stakeholders, people who make decisions that worked together for over 2 years. We met by Zoom, sometimes on a daily basis, sometimes on a weekly basis, depending on what was going on with COVID, but that really worked hard to understand the challenges and to understand the perspectives and the interests of different members of our community in making decisions. So who do you see on the screen? Well, there's different groups of people. So up here in the upper left, these were our elected officials. This was the mayor of Austin for most of the pandemic, throughout most of the pandemic. These were our elected county judges, first Judge Eckhart and then Judge Brown. County judges they're not necessarily, they're not judges in the sort of legal sense that you might be thinking of it. These are elected officials who are really responsible for making decisions that have to do with community safety and things like that. And so when there were things like stay-home orders or face mask orders, it was actually county judges around Texas who had the authority to make those decisions. So these are the chief decision makers, the elected decision makers. Then the people in the lower left, these were our public health authorities. These are people who have spent their careers in medicine and in public health and are responsible for serving the community. These are not elected positions. These are appointed positions. These are career positions. So these are heads of our public health agencies, and these are called also the public health authorities for our region. These people up in the upper right, these were executives, chief executive officers, chief operational officers in the 3 private healthcare systems that serve the Austin area. So these are the people who run the hospitals, and they are making decisions both based on what's in the best interest of the community, but also what's in the best interest of the bottom line and the integrity of the for-profit entity that they work for. And then you had us in the lower right. These are clinicians and researchers at the University of Texas at Austin that were invited to help provide expert guidance from a sort of academic perspective or scientific perspective. So we all worked together. And my role was really to provide guidance and do analysis, not to make the decisions, but I was there in many of the discussions, providing information as best as I could. Okay, this team, thanks to our leadership, thanks to our mayor and our judges, really led with science. They were the ones that invited the scientists to the table. They were the ones who were looking at the data and really trying to understand things as deep as possible, as deeply as possible throughout the pandemic. This is a screenshot of the news briefing, of the newscast in mid-March when Austin leadership first announced we were shutting down and staying home. So this is the mayor on TV saying, we're enacting the stay home, work safe order. Everybody has to stay home and stop working starting tomorrow. And what he's doing here is he's pointing to a graph. What is that graph? That is a graph that was a graph that we produced. They asked us to model the spread of COVID in Austin and to run a bunch of different scenarios. What would happen if we did nothing to shut things down? What would happen if we enacted policies that reduced people's daily contacts by 50%, by 75%, by 90%? We ran those simulations. What you see is the results of those simulations. So this is the projection of what would happen through time, starting in March, going through July. And what you see here, the y-axis here, this isn't cases, this isn't deaths, but this is hospitalizations. We were projecting how many people would end up in the hospital with COVID. And what you see in the colors here is the blue region is the number of hospital beds we had. And the red is when the projection said we would far outstrip our capacity. And why were we projecting this? And why were we shutting down at the time? Well, I don't know if you remember this, but in early March, before we shut down, we were seeing horrific images and terrible stories from Italy, where the hospitals were being overrun and people were dying in the halls. Same thing from New York. We were hearing about morgue trucks that were needed to collect the bodies because there wasn't room in the morgues, and the hospitals that were being completely overrun. So all over the world, we were worried about deaths, absolutely, but the imminent fear was our hospitals were going to be overrun, and nobody would get the health care they needed. So that is what was imaged here. And so the leadership of Austin said, hey, we're going to go out and we're going to explain to the public and help them understand the science and help them understand the scenarios we were facing so that they could really buy in and understand, and we could be as transparent as possible about the decisions we're making. So they led with science from day one. They asked us to do analyses to help protect vulnerable populations. They asked us to calculate what was going to be the risk to the construction workforce if they reopened construction work during the stay home period. They asked us, and actually the predictions were pretty grim, that people who worked in the construction industry would end up being about 5 times more likely to end up in the hospital with COVID than other people in the same age group who had different occupations. And unfortunately, the city actually couldn't, the state mandated that the construction industry was open and the city couldn't do anything about it, but they did track the hospitalizations. And sadly, our projections were almost exactly right, that in the first 6 months of the pandemic, construction workers were about 5 times more likely to end up with hospitalized COVID than other people. They asked us to project how many, so they were worried about the population experiencing homelessness in Austin, and that when COVID really started spreading, they needed to have places to isolate them because they didn't have homes in order to protect the population as a whole from transmission. And so they asked us to project how many isolation rooms they would need for the population experiencing homeless at the peak of a COVID wave. And so we did that. And in fact, I have research articles here, but the first 2 names in this study were undergraduates at UT who volunteered and said, how can we help? And they did these calculations. They projected that the city would need about 200 isolation rooms. The city procured 200 hotel rooms from hotels to use as isolation facilities because at that time, nobody was using hotels because nobody's traveling, everyone was at home. And when we look back, those projections were almost exactly right. At the worst peak in Austin, they used almost all 200 of those rooms to isolate people who didn't have anywhere else to isolate. So I'm going to just talk about one more project we did for the city. And this is a modeling project that we did to help them navigate what I think was probably the biggest challenge that every community faced, and a challenge that most communities didn't figure out how to solve. So what was that challenge? Well, we had this tension. We were seeing, these are pictures from this, I think these are from Italy and New York. These are the morgue trucks I was telling you about, and hospitals being overrun. We didn't want our cities and our communities to suffer in the way we saw communities suffer. All right, so did it work was the question. The answer is sort of. There was this one surge where we went over our capacity, but that was actually user error. The system told the city that they needed to go into red and they waited 2 weeks. And then the other question is, did we keep things open, more open than other cities? And the answer is yes. I don't have a graph to show you, but this is what happened. In Texas, the Texas governor had this order that if your ICUs got to 15% full if 15% of your ICU was filled with COVID cases, you automatically had to shut down elective surgeries and other sort of more elective healthcare processes. And this applied to all cities in Texas. And Austin absolutely spent the least amount of time among all Texas cities under this very restrictive order. So we were able to keep our economy more open, our schools more open than many other Texas cities, because we followed the system where we really didn't close down unless we really, really needed to in the very end. There were systems like this all over the world in different cities, schools, universities, industries, and most of them were just built based on intuition. Many of them weren't used for very long, and many of them didn't work very well because they weren't based in science in the way ours was. For example, one that was introduced by Harvard that was widely used earlier in the pandemic, it was very conservative. If you followed it, you would be shut down much more than you needed to be. The one that was used in France to shut down different cities as their ICUs got full, it was sort of a whack-a-mole type of system. It was too liberal. Hospitals got overrun by the time they actually shut things down. And so there's sort of this like Goldilocks, right? This sort of sweet spot, but you really have to use science and modeling to understand exactly when you need to enact policies in order to protect your population while keeping it as open as possible. So even though our system was designed to protect our hospitals and keep our society open, the things Austin did really did save lives along the way. This is a graph showing COVID mortality per capita throughout the first couple of years of the pandemic. These are 5 major Texas cities. Austin's overall per capita mortality rate was less than half the state's average and much lower than other major cities. And when you compare this to other similar sized cities in other parts of the country, Austin's per capita mortality rate was less than half the US average and much lower than other similar sized cities. So in other words, if you lived in Austin, you had about, twice the chance of surviving COVID than if you lived in other cities. So even though I have some final things to say, I'm going to stop there. Just I gave you a sense of it. We're still hard at work trying to prepare the world for the next pandemic. And there's so many people who contributed to the work that I described to you today. So happy to spend a few extra minutes if anyone has any questions that they'd like to discuss.
First, thank you so much for that wonderful talk. I mean, to me, I find your work and your research to be very fascinating, and it just is kind of mind-blowing to me the global impact that it has on people. So thank you for taking the time to share a little bit with us today. Question is, what is the probability of bird flu becoming transmittable between humans in the next 12 months? 64K question. It may not have a qualitative answer.
Yeah, it's really like more like a $3 trillion question. I mean, it is the question, right? Like if we had a deadly bird flu pandemic, it could be even more devastating and, just globally disruptive than COVID. The 1918 Spanish flu pandemic was, more than twice as deadly as COVID, and it killed people who were young and healthy, right? It's really was a different and in many ways worse beast than COVID. So there is a very plausible scenario where we have something much worse than COVID emerge and spread. And it could be a bird flu that becomes human transmissible. I'm not answering your question because I don't know the answer to the question. I mean, it really is the question so many people are hard at work trying to answer. But let me just tell you some things that make us more concerned it could happen soon and less concerned it could happen soon. So first of all, H5N1, which is the subtype we're most concerned about right now, the one that is causing infections in cattle. And we've, for the first time, are having dozens of people get infected in the United States when they're exposed to infected animals, cows and birds. We have known about H5N1 since 1997, right? So 97, 07, 17. So we're almost 30 years, right? Like we've known about this for a while. And when we first became aware of H5N1 in 1997, it was incredibly alarming. In fact, it is really what inspired so much of the investment in pandemic preparedness that has happened over the last 30 years. It's partly what inspired a lot of my work leading up to the COVID pandemic. A lot of the work I did prior to COVID was building models of what happens if we have a bird flu start spreading in the United States. So why was it so scary? And why is it so scary? Well, before the recent outbreaks in the United States, we'd have these really devastating outbreaks in poultry, and occasionally people who were working close with these infected chickens, they would get infected. And it was so scary because up until recently, about half of the known human cases of H5N1 died from it. A 50% case fatality rate. That is crazy, right? COVID had a less than 1% case fatality rate. The 1918 flu had an estimated maybe 2% case fatality rate. Half of people dying would be just beyond catastrophic, right? So it's so deadly. So this is what was making us scared, right? We have this really deadly virus. It's occasionally infecting people. And so what we were worried about and what we have been worried about is that virus evolving the ability to spread from person to person. That hasn't happened. Like every single case of H5N1 that's happened has been a transmission from an infected animal to a human, right? And so what we've been waiting for and worried about is the scenario where something happens. And it's a longer lecture about how that might happen, but like one possibility is you get a pig infected with H5N1 and infected with a human influenza virus at the same time, those two viruses combine genetic material in the single infected pig, and what comes out is a virus that's as deadly as H5N1, but has the ability to spread from person to person. Now, that hasn't happened, but we believe that scenarios like that is what has led to the prior influenza pandemics in humans. So that's what we're really worried about. So we've been worried about it for a long time, but why are we more worried about it today? Well, because we now, for the first time, have H5N1 infections in cows, and those cows are here in the United States. Like, that's really scary. That's like a new species, a new host, and it's a host that's close to home. And it's scary because there's been a handful of people now that have gotten infected by working with infected cows. So that's all really scary. A new mammalian species, and a species that we are close to here in the United States, and we're seeing infections in cats and other mammals now. So that's scary. Okay, what makes me feel like, why am I still going to work? And why have I not stockpiled, which is something I did early for COVID, right? And told my kids to stay home. Why am I like, okay, it's not happening tomorrow. It could happen tomorrow, but I'm not like sure it's happening tomorrow. So here's a few things that just make me feel like we are doing the right thing. We're in a stance of really closely monitoring. We're trying to make vaccines already for this because we know it could happen. Like, we're doing everything we can to prepare, but we're not telling people to stay home. Number one, we've known about this since 1997 and it still hasn't emerged into a human transmissible strain, right? So, I mean, it absolutely could happen, but it hasn't happened yet. And there's no guarantee it's going to happen tomorrow. And even though like it feels really acute because it's here in the United States, we have had some pretty serious H5N1 stuff in poultry, in wild birds, in other parts of the world over the last 30 years, right? So hasn't happened yet. The other thing that makes me just curious about what's going on is that up until this outbreak in the United States, half of reported cases have died. If you look at the reported cases since 2024 in the United States, the vast majority of them have been exceedingly mild. Literally, people have pink eye, and that's like their only symptom, right? If you look at the reports in the CDC, most of them, the only like reported symptom is conjunctivitis, right? And so that's much milder than what we've heard about. That said, one person did die, and that person had underlying conditions, high risk. It's thought that they were not exposed by cow, but birds. There is someone else in the hospital now. So like, we're keeping an eye on it. And it may be just that we're looking at this so much more closely that we're catching mild cases, and we just didn't catch mild cases in prior outbreaks. Like, we just don't know. Is it really milder? Is it how we're monitoring? So there's a lot of questions that we don't know the answers to. We've been preparing for this for 30 years because we really believed this could happen, and it still really could happen. And it could happen in the next month, but it could also maybe not happen in the next month. So I don't have an answer, but I'll tell you, there's a lot, we're watching it very closely. We're trying to prepare for the scenario where it does emerge, in the near future. And we don't have the models to predict that yet, like how close something is to jumping into humans. We just don't have the science or the models, but we're using our models to do everything else to be able to detect it as quickly as possible when that happens, and to be able to respond as effectively as possible.
Thank you. It's a very insightful answer. We did have another question come in. It says, this is so fascinating. I'm a teacher in Indiana preparing a project-based public health course. I'd love to explore how high school students can apply principles of modeling to local public health issues as they work alongside our local public health officials. Do you have any recommendations on how to best incorporate this? I don't have a background in data science, so if you have any suggestions for a primer or foundational resources to help me design a meaningful course, I'd greatly appreciate it.
Yes, I believe there are some really good resources online. And in fact, there is one I just ran across. I might be able to find it in like 15 seconds. And if not, then you should email me and I'll get back to you. But there is a really nice online simulator of disease transmission. This is what it looks like if you follow this link. So this is an actual whole lesson plan about how you can teach kids about, they can use models to simulate disease spread. And if you click on this, you get to the thing, and then you can enter all different kinds of scenarios and watch these red death and cold, and you can change what your population makeup is, and like watch these epidemics unfold in a population. You can see these little dots represent people, and you can see them getting infected and then recovering. And this curve is tracking how many people in your population are infected and recovered through time. So I think that's a great starting point. And if you're looking for more resources, don't hesitate to reach out.
Thank you so much. And yes, with that, if there are any additional questions or anything like that, you can contact me and I will definitely forward them to Dr. Myers and get you an answer. I do have one question. I know when you're dealing with mathematical models and numbers and stuff like that, there's usually some type of uncertainty. So how do you all deal with that uncertainty and variability in the models, like especially when it comes to predicting the impact of new interventions or, the emergence of new variants and stuff like that?
There's so much uncertainty in the world, and then and then there's so much uncertainty that in our models, and there's different kinds of uncertainty. So, we may know the average transmission rate of a disease in a city, but like it's not going to be the same transmission rate in every school and every household and every neighborhood, right? And so we're often putting averages in that don't fully, and there's uncertainty about, how people deviate from those averages, and there's a lot of variation. So there's uncertainty in kind of like the local heterogeneity. There's uncertainty even if we think we know the transmission rate of a disease, we really don't know it. We're like estimating that from data. So we might say, I don't know if you've heard of the reproduction number. The reproduction number is a number we often estimate. It's if somebody gets sick, what's the average number of people they're going to infect? So we try to estimate that. We go back and we look at data from COVID, and early on, people were trying to estimate what is the reproduction number of COVID, and the estimates, depending on what data you were looking at or what method you were using, ranged from a reproduction number of 2, every person was infecting on average 2 other people, up to 7, like every person was infecting on average 7 people. So, that's, not even getting to the uncertainty you talked about, which is what's going to happen in the future. That is like uncertainty about what's happening underfoot because we just have limited data to understand things. And then there's the uncertainty about the future. I'm trying to make a forecast of how it's going to spread. I don't know how people they're going to wear their face masks tomorrow. I don't know if they're going to change, the governor's going to change his policy next week. There's all these things. I don't know if there's going to be a hurricane in Houston that causes all these people from Houston to come to Austin in the middle of the pandemic and stay in gyms and really sort of amplify content. That there's all these things really happen, right? And you don't anticipate them. So there's so much uncertainty in the world and in the things that really are important to understand when you're trying to make predictions about an outbreak. So what do? Well, we use our very best guesses as inputs to our models, but we also will run simulations across the range of possibilities. So we may think that the best guess for the reproduction number of COVID is 3, but we may say we really aren't sure. It could be 2, it could be 7. And what we'll do is we will often run simulations across that whole range. So then when our projections, we can see the whole range of projections. I mean, this is one of the dashboards. I'm going to show you guys something. Let's see. We had these dashboards up throughout COVID, making forecasts to help locally. So this was a dashboard showing what was going to happen in hospitals in Texas. And you can see the actual hospitalizations, and then you can kind of zoom in and you can see these were the forecasts that we were making at that point in time. And how did we visualize uncertainty? Well, instead of just giving you one forecast, we put a bunch of do you guys see all these different gray lines? Each one of those is an equally plausible future trajectory that our model projected. So even though we're showing this is sort of the middle one, it's equally likely we end up here and equally likely we end up down there. And we're just showing you, and what you can see where you see this cluster of forecasts, what it's telling you is that most likely things are going up. Most likely they're kind of going up in this sort of medium range, but it wouldn't be crazy if there was a sudden spike like this. And, I'd be happily, pleasantly, not too surprised if it was low down there like that. So what we do is we run simulations across the entire range of what we think is plausible, and then we try to visualize that uncertainty so the people who are using our projections really understand what we do know and what we don't know.
Wow, this is really cool. Thank you. We do have one more quick question. They say, how can high school students join in this research? Who to contact?
Great. So wonderful question. And there are many labs around the world that do work similar to what I do. Many of them are in public health departments. I happen to be in a biology department and sort of a main sort of arts and sciences college, but find people all around. You can look for research you find interesting, and you can just send emails to the professor saying, "Hey, I'm a high school student who is really interested in this kind of work. Do you have opportunities for high school students to get involved?" You can certainly send me an email. When you're sending those emails, it's good to tell the professor a little bit about yourself. You know what your back if you're actually interested in modeling and doing this kind of like data modeling and things like that, it'd be good for you to tell the professor you're interested in working with what your background is and what classes have you taken in math or statistics or coding or what any other experience you have in research that might be useful. Even if you don't have a ton of training or classwork, if you're really interested and you express you're really interested in learning these things, you'd be happy just helping out in like a sort of collecting data or figuring out inputs from models, like that's fine too, but you just sort of want to communicate what you can do at this point and what you'd like to learn to do in the future. And don't be afraid to send follow-up emails. People are very busy. Professors get lots and lots of emails, especially when they're teaching. And I have 70 students in one of my courses and they're all emailing me. And so, my inbox can get pretty full. And if they don't respond, it doesn't mean they don't want to respond or they're not interested. It may just be that they're very busy. So don't be shy about if you don't hear back in a week or two saying, "Hey, I'm just reaching out again. I'm really interested and would love to hear from you."
Thank you. So with that, we're going to close our session. But again, if there are any other pressing questions, please don't hesitate to email me. I will put my email in the chat so that you all can notify me. And let me share my screen. I have just two more closeout slides to do really quick. So I would like to give a special thank you to our sponsors for supporting us and making these cost-free webinars possible for you all. You can see them here on the screen. And then lastly, thank you again to you all for joining us. It was a great talk, Dr. Myers. We really appreciate you taking the time to do this today. And then last but not least, we have QR codes up here for survey links. If you all that are still here wouldn't mind to take a minute to do it, your feedback makes it possible for us to serve your needs. So please take a second. It just takes a minute to fill them out. And with that, that is the end of our webinar for today. Again, thank you all so much for being here. We really appreciate it. And again, special thank you to you, Dr. Myers. It was a great talk.